Welcome to our session. This is our first session on the systemic juvenile idiopathic arthritis. We're happy to have you here. We'll just give it another minute as some people are joining. I hope you're able to make it to the opening session. It was very nice to hear all of the updates. Okay, we don't have anyone else in the waiting room, so I'm going to go ahead and get us started, I think, if everyone's okay with that. My name is Julie Kieser. I am a JA mom. I am a host for this session, and we are pleased that you are all here. We are also very happy to have Dr. Canna, who's also here to help us learn about JIA. Systemic JIA and what we can do. Just a reminder, this session is recorded, and I had one other announcement I wanted to give to you. So this is the first of 3 sessions on systemic JIA, and our campaign is to provide education, support, and resources to families with children with SJIA. This series will cover the physical, social, and emotional effects of having systemic JIA, each with having lots of words and wisdoms from family dealing with this condition. This is a new systemic JIA resource and is being independently produced by the Arthritis Foundation, made possible with support by Novartis Pharmaceutical Corporation. I also wanted to remind everyone that there's a great active page through the Arthritis Foundation of coping with systemic juvenile idiopathic arthritis, and that is that link is available in the app, the conference app. And with that, I am going to turn it over to Carrie, who's going to introduce Dr. Canna.
Hi, everyone. Thanks for joining us today. My name is Carrie Cupp. I'm with the Systemic JIA Foundation, and I'm going to introduce Dr. Scott Canna, who's one of our favorites and is such an activist on behalf of all of our SJIA children. He comes to us by way of NIH, University of Pittsburgh Medical Center, and now he has found himself at Children's Hospital of Philadelphia. Thanks for joining us today, Dr. Canna.
Thanks so much for having me. It's really great to be part of this group. It's great to see some faces I haven't seen for a while, and hope we can have a good conversation today. Can everybody hear me all right? All right, I'm getting nods. Okay, so we'll keep things simple. Systemic JIA, we're gonna try and talk about what it is to the extent that I have an idea what it is, and how do we work on making it better. So, you know, nothing relevant in terms of disclosures, but I do run a clinic, but I also run a lab, and that lab sometimes gets support from pharmaceutical companies. So I thought I'd start with a few cases. I don't think any of these are known to people on the call right now, but they're certainly not meant to be. These are, I certainly have permission for all of these pictures. So, you know, is this SJIA? So this is a 2-year-old that I saw not long ago, who I saw now after 14 days of fever and just misery. Maybe some runny nose or some kind of stuff like that on day 1 or 2, but nothing since then. Now the fever, when it used to come sort of randomly or all the time, now seems to come only in the afternoon. He has this rash that he developed at around 5 days of fever. It's certainly worse with fever, but it's there all the time, and you can see pictures of it. He feels a little bit better with ibuprofen, and the fever comes down, but certainly isn't making things better. So when he got admitted, he got this medicine called IVIG out of presumption for another disease called Kawasaki disease, and didn't really have much of a response. And part of that admission, you know, we looked for infections like strep throat or a viral respiratory viral panel, and all that was negative. And this poor kiddo is still showing lots of inflammation. And then finally, when we came by, we said, you know what, your left knee is a little bit swollen. But nobody, the parents or the other docs, really had picked up on that and hadn't seemed to be bothering this little 2-year-old. So is this systemic JIA? What about this little guy who I saw for many years, starting when he was about 10 years old, who had had a prolonged fever illness before I met him. And then, part of the way into that, his knees and hips started hurting him. He never noted any rash. And by the time I saw him, he now hadn't had fevers or rash in a long time, but had some of the worst arthritis I'd ever seen in 27 joints. And, this is his MRI, and not that you're supposed to know what x-rays and MRIs look like, but, this x-ray here, I don't know if people can see my cursor. Maybe I should switch to the leader pointer. There's supposed to be some space in here where the cartilage goes, but the arthritis is sort of gobbled that all up. And then on MRI, this is supposed to be much more smooth, this area here, and it's all rough and sort of broken up from having chronic arthritis. And then finally, there was this young lady who I saw at about 18 months of age. She was known to have trisomy 21, also known as Down syndrome. And she had had fever for about 10 days. And she immediately got pretty fast with sick pretty fast with a big liver and spleen, anemia, low platelets, an irritated liver. And then actually, some low blood pressures and shock, requiring her to go to the ICU for quite a while, and had a huge workup that never showed any kind of infection or malignancy. Never any arthritis that we ever found. And so does this young lady, and her little rash, is this systemic JIA? So maybe we'll answer that question over the course of this presentation, but I thought I'd start with a little bit of history. So this is George Still. He was a pediatrician in London back in the late 1800s. He lent his name to lots of things, as was the trend in the time, including the Still's murmur, which is a very benign musical heart murmur. He actually was the first to describe ADHD. But he also lent his name to this thing called Still's disease, which was this life-threatening systemic inflammatory syndrome that, stayed as Still's disease for, quite a while. I can't see that's fine. It wasn't until 1963, 50 years later or so, that Still's disease was sort of renamed systemic juvenile chronic arthritis. And, it was mostly, part of all the other kinds of juvenile arthritis. And then, about 13 years after that was when we really had this breakup of the different kinds of JRA at the time, oligo, poly, and systemic. So this is the current criteria that most people use to define systemic JIA. And these criteria say you have to have arthritis in at least one joint, and you have to have fever for 2 weeks. And for at least 3 days of that 2 weeks, it has to have a quotidian pattern, meaning, comes at around the same time every day. In addition to that fever and arthritis, you have to have at least one of the following, and that's a rash, swollen lymph nodes, a big liver or spleen, and serositis. And so let's talk a little bit about what those are. So these are a bunch of rashes. These are rashes from patients I've seen or patients that I've sort of collected from colleagues. And, which one is the Still's rash? Who can guess? We'll have our little salmon jump around. It was actually this one here. But the reason I show this slide is really to say there are lots of different rashes that can change over time that can look like Still's disease. The Still's disease rash, or the systemic JIA rash, because we're really talking about the same thing, is described to have a salmon pink color and to be evanescent, meaning that it changes over time. Especially, it seems to be more prevalent when they have fevers, which is not surprising. So this is actually the causes of all these other rashes. I forget where I got this one from. This is the rash of strep scarlet fever. This is cryopyrinopathies, familial Mediterranean fever, TRAPS, hyper IgD syndrome, and of course, Kawasaki disease. And, I think for those of us in practice, trying to distinguish these diseases just based on rash is not really something that we can do easily. So to go through the rest of the ILR criteria beyond the rash, generalized lymph node enlargement. So you can have, big lymph nodes anywhere that you have lymph nodes. We're most used to the ones in our neck because those get swollen practically every time we get a cold or sore throat. But you also have lymph nodes in your armpits called axillary lymph nodes, or in your groin. And you actually have lymph nodes in and around your lungs and in and around your intestines. You kind of have them all over your body. And so that lymph node enlargement need not be something that you can see or feel. And then, hepatomegaly and splenomegaly, this just means that your liver is big or your spleen is big. Big is a relative term. Obviously, if you know that you have a big liver or spleen, then it's usually quite big, but this can be hard to detect, even for us at the bedside, especially if you have some belly pain. And then serositis is another word you may not be familiar with. That refers to itis, which is just inflammation surrounding, certain areas within the body. So serositis includes pericarditis, which is itis, inflammation of this sac around the heart called the pericardium. And of the serositis of systemic JIA, pericarditis is probably one of the more common ones. But you can also get pleuritis, which is inflammation of the lining sort of in and around the lungs, not necessarily in the lungs, but of the lining around the lungs. And then peritonitis is inflammation of the lining of the abdominal cavity. So all of this area where your intestines and your liver and your spleen and your stomach and kidneys, where all of that stuff lives, has this lining that can become inflamed in systemic JIA. But perhaps the most important criterion is not something that's listed there, which is that you don't have something else. Systemic JIA diagnosis of exclusion. So you can have all of those other things, fevers, swollen lymph nodes, rash. If you have an infection, or you have, God forbid, a malignancy, or one of these other sort of weird metabolic or autoimmune or genetic diseases, then you don't really have systemic JIA, even though to all the world you might look like you do. This makes diagnosing systemic JIA often really hard and not something that you can do right away because you have to rule out all these other things. Now, a little bit about the epidemiology of systemic JIA. It is not the most common form of JIA, as we all know. It's usually described as about 10% of all the JIA patients. Mostly occurs in younger kids, the early peak somewhere between 1 and 5 years. And unlike other forms of JIA, there's really no difference in the incidence of this between boys and girls or people of different ethnicities. In adults, if you have this syndrome that comes on after the age of 16, then technically this should be called adult onset Still's disease, because there is no JIA for the adults. And so they still call it Still's disease, recognizing that the original Still's disease was a pediatric disease that we no longer call Still's disease. So the course of systemic JIA classically was this rule of thirds, that a third of patients had what was called a monophasic course, where they'd be sick for weeks, sometimes a couple months, but eventually with treatment, things would go away, stay away, and never come back. And then another third would have a relapsing course where things could come and go, but were there for often many years. And then, a third of patients had a chronic course. Over time, and we don't have good numbers on this, but the suggestion is that actually more patients are in this monophasic bucket, if you will, where, as many as a half and sometimes some series even more of patients will have this sort of acute febrile disease and, get treated with something or other, and then it goes away and stays away. And maybe that's because we have newer medicines that maybe do a better job of sending it away and keeping it away. I also think, and this is maybe just me speaking here, that the distinction between this relapsing course and this chronic course is probably not so distinct. And in fact, both patients probably have ongoing disease throughout their lives with sort of ebbs and flows, just like any autoimmune disease does. So we talk a lot about cytokines in systemic JIA, and I thought it was worth, for those who aren't constantly thinking about cytokines like I am, thinking about what is a cytokine. And so to start with, we have to talk about some of the cells that are causing problems in systemic JIA. And those include cells like macrophages that are sort of big and sort of this funny shape, and they are big eaters. That is what macrophage means. And so they tend to gobble things up. But they also can make a lot of cytokines like IL-18 in red and IL-1 and IL-6. We also have lots and lots of neutrophils. Neutrophils are actually the most common immune cell in your peripheral blood, and they can be a really big source of IL-1. And then, of course, T cells are also part of the problem, especially in many systemic JIA patients. And T cells also make cytokines, and they can make interferon gamma and sometimes a little bit of IL-6. And of course, there's dozens of other cytokines, but these are the ones that we sort of think about and talk about in systemic JIA. And cytokines are really just ways for immune cells to talk to each other. They're maybe like text messages between immune cells. Some of them can be rather inflammatory, and I'm sure you've all received text messages that were rather inflammatory. And some were, maybe a little more calming. And so there's all different kinds of messages that these cells send each other. Now we can measure some of these, or we can measure the byproducts of some of them in, patients. Many of you or your children will have had these tests. And so I'll just sort of go through some of the ones that we follow. So we talk a lot about the neutrophil count as part of the white blood cell count when you get a CBC. Now, like all blood cells, neutrophils come from the bone marrow. They're often higher in patients who have inflammation, but in systemic JIA, it may be, this is sort of preliminary data, that if you're a systemic JIA patient and your neutrophil count is high, that might actually be good for you in the long term in terms of a prognostic indicator. The platelet count, so platelets are usually these little bits of broken off cells that are used for clotting. If you have chronic inflammation, platelets can be high. High is probably better than low. If your platelet count is low, that might mean you've entered into a more severe phase of your systemic JIA called MAS. We'll talk about that. Hemoglobin, also hematocrit. Hemoglobin and hematocrit measure exactly the same thing, which is how much of your blood is made up of oxygen-carrying cells or red blood cells. And this is usually low, both because of inflammation and potentially because of other things like anemia. Albumin is something that we measure in the blood. The albumin is made by your liver, and it is one of the most abundant proteins in your blood. And it's mostly in your blood like a sponge to keep water and fluid inside your blood vessels. If your blood vessels get inflamed and leaky, like they can in systemic JIA, albumin can leak out. And so we'll often follow this in inflammation to see kind of how inflamed and leaky your blood vessels are. Many of you are familiar with the ESR, or erythrocyte sedimentation rate. How it's done is sort of old and antiquated, but this represents mostly a measure of fibrinogen, which goes up in inflammation. But we use this as a marker of inflammation. It's usually high in inflammation. If it's low, again, that can be something especially concerning. If we think there's a lot of inflammation, we expect your sed rate to be high. If it's not high, that makes us actually more concerned. The CRP, or C-reactive protein, again, comes from your liver, and this is made in response to this cytokine IL-6 that we talked about. And we like the CRP not because it tells us exactly what disease we're dealing with. It's actually very non-specific, but because it's very sensitive. It goes up with inflammation, it comes down when the inflammation gets better, and so we can follow it over time. The AST and ALT are liver damage markers that we often look for in systemic JIA, both as part of the disease or potentially as side effects of treatment. And this just comes from damaged liver cells. The LDH, or lactate dehydrogenase, this is another thing that kind of gets leaked out of dead or damaged cells. This is present in all of our cells, so it doesn't tell me what kind of cells are being dead or damaged. It could be immune cells, it could be liver cells, it could be muscle cells, it could be all the above. But again, it goes up and down pretty quickly, and so it's good for following someone over time. Ferritin, many of you are unfortunately painfully familiar with, is one of our favorite biomarkers of macrophage activation syndrome. It comes from liver cells as well as macrophages, and it's very sensitive for this HLH-MAS thing that we'll talk about in a little bit. Some of the things that are a little bit harder to measure, but we still can measure clinically, are things like S100 proteins. And these are secreted or potentially exploded out of immune cells, mostly neutrophils. And this might be a little bit more specific for diseases like systemic JIA. My lab studies this cytokine called IL-18 or interleukin 18. And we think that IL-18 is actually, when it's really, really high, something that we almost never see anywhere but systemic JIA or macrophage activation syndrome. So it might actually be helpful as a specific biomarker. And then there's another one called soluble IL-2 receptor or soluble CD25 that we'll measure sometimes in patients who are worried about MAS or HLH. And this is another marker of disease activity. So hopefully this is ringing some bells for some of you familiar with them, or hopefully it's not for some of you who will never have to encounter them. So let's talk briefly about what causes systemic JIA. And the answer, the most honest answer, is we don't know. And I like to say that systemic JIA has been helping to keep the I, which stands for idiopathic, in JIA since 1896. So idiopathic means the idiots, that's us. We don't understand the pathology. And we don't really understand what causes systemic JIA. We have some ideas. Certainly in some patients, what we call systemic JIA seems to be a prolonged or abnormal response to something like a viral infection. And often we never know what the infection was. If any of you are familiar with a disease similar to MAS called hemophagocytic lymphohistiocytosis or HLH, that can be associated with killing defects. And if people want to geek out about that, we can get really far into it. That may be a contributor in some systemic JIA patients, but it's certainly not the whole story. We will talk a little bit about this concept of autoinflammation and how this cytokine IL-18 that my lab and others study might be rolled up in that a little bit. But as I said, the honest answer is we don't really know. We have some good guesses and we have some sort of ballpark estimations of what kinds of things are important in systemic JIA. So I thought it was worth talking about the concept of autoinflammation. And so my favorite definition of autoinflammation is persistent inflammation that is not explained by infection, malignancy, which is cancer, or autoantibodies or antigen-specific T cells. And so this is what we traditionally think of as autoimmunity. And so autoinflammation is sort of inflammation that's not infection, cancer, or autoimmunity, like lupus or like the other forms of JIA are probably more in the autoimmune side of inflammation. But I made this to sort of remind people that when the immune system goes wrong, it doesn't follow rules or doesn't fit into one, easy way of thinking about things. There's lots of overlap between autoimmunity and autoinflammation, and even other ways of the immune system going wrong, like lymphoproliferation, like you might see in, some kind of leukemias or lymphomas, immunodeficiency, and even allergies. Sometimes we'll see some allergic type symptoms in systemic JIA patients. And then, this is the frustration that I feel, and I'm sure that parents feel as well, when we keep talking about these categories of exclusion or diagnosis of exclusion. So I sympathize and I can only say we're working on it. So I'm not going to belabor this point because Mike Umbrello is actually talking later today, but one of the things we know that about systemic JIA is that it's not like other forms of JIA. And this largely comes both from our clinical experience, which says that this really is a different animal, but also from the genetics, which show that there are some genetic risk factors for systemic JIA, and they seem to be pretty much completely distinct from the other kinds of JIA. One of the things that we've been following a little bit in JIA is this idea of a window of opportunity, which is that the beginning part of systemic JIA is often different than what happens weeks, months, or years after onset. And so in the beginning, you have this more autoinflammation side of things where, you have blood vessel inflammation and all these innate immune cells, and that can cause some arthritis. But then later on, this chronic inflammation can lead to more of an autoimmune problem, which is why we sometimes will see more typical poly-JIA type features in some of our chronic systemic JIA patients. And the hypothesis, and this is just a hypothesis, is that if we do a better job in the beginning, we can maybe prevent more patients from developing into chronic systemic JIA. And maybe, we don't want to pat ourselves on the back, but maybe this is why that rule of a third is more like 50% of patients are monophasic, because we're doing a better job in the beginning. So one of the complications of systemic GIA that I think we all think about and maybe fear the most is called macrophage activation syndrome, or MAS. And this is what it is. It's, again, prolonged fever, kind of like systemic GIA. Instead of high white blood cells, they have low white blood cells. Instead of high platelets, they have low platelets. They have abnormal clotting and can have bleeding problems. They can have liver irritation that we call hepatitis. They can have this weird thing that we usually look for in the bone marrow called hemophagocytosis, which really just means some of your macrophages have eaten other things in the blood. And so this is a hemophagocyte. It's a big old macrophage. And inside of it, you can see here are 4 red blood cells. And this is probably sort of a partially digested neutrophil or lymphocyte. Exactly why that happens or what it means, I don't think is actually worthwhile discussing here, but it is something that you'll hear about, and it is part of our diagnostic criteria for macrophage activation syndrome. I've highlighted ferritin here because, as far as we can tell, we don't really ever see macrophage activation syndrome in patients who don't have at least a significantly elevated and often sort of through the roof elevated ferritin. And the reason we worry so much about macrophage activation syndrome is, in addition to being sort of uncomfortable, if you don't do anything about it, it can lead to organ failure and shock, like in that one patient I described at the beginning. So what isn't macrophage activation syndrome? Well, it's a syndrome, which means it's not so much a diagnosis. It's more of a ballpark. Syndrome comes again from the Greek for just flow together. And so a syndrome is just a collection of symptoms that flow together. I tend to think of MAS a bit more of a description of the state of your inflammation at a given point in time. To say right now, you have these features, of low platelets and liver irritation, and your ferritin is through the roof, and that is sort of MAS-like. But, biology rarely works like a light switch where you have MAS and not MAS. In fact, I can only think of a couple things in all of biology that are sort of yes/no answers. And I don't think MAS is one of them. I tend to think more along the lines of, for many, not all, but many systemic GIA patients, their active systemic GIA is on a spectrum that can lead to MAS. And MAS is just the sort of more severe end of that spectrum. So why do we call it macrophage activation syndrome? Well, we think, and when we're looking at these hemophagocytes and whatnot, that you see a whole bunch of angry macrophages. And so they're activated. And so we just call it macrophage activation syndrome. That's not a super helpful description, but that is the sort of state of the art of what we call it. And here I show a picture of the dreaded activated hemophagocyte. So MAS is part of this collection of cytokine storm syndromes that, are all distinct, but all can lead to, organ pathology. And so I show this slide just to say that there's a fair amount of overlap between systemic GIA-MAS and infection-associated inflammation, and even this MISC thing that we think about in association with COVID. And here's, familial HLH for those who are thinking about it. So there's, all of these cytokine storm syndromes, and MAS is sort of one subtype, one flavor of them. So if I'm being honest with myself and with all of you, what is SJIA really? Well, it's a little bit of a wastebasket diagnosis, meaning we take all of these things that kind of fit the right bucket and we toss them into the same place. And what you will include as systemic GIA as a rheumatologist sometimes differs. In fact, I'm at the Children's Hospital of Philadelphia. I work closely with this guy, Ed Behrens, who is also a MAS systemic GIA researcher. And we will often disagree about whether the same patient does or doesn't have systemic GIA. And I think I'm right and he thinks he's right, largely based on, are you lumping different patients together to say that they're similar enough? Or are you splitting them to say that their differences really are functionally important? So one way of parsing some of these different kinds of systemic GIA is, again, through some of these cytokines and biomarkers. And one of the ones that we use, and this isn't actually data from my lab, it actually predates me having a lab, is looking at IL-18 and maybe in particular comparing it to IL-6 levels, that the patients that have really high IL-18 levels tend to be the ones who have more problems with inflammation and macrophage activation syndrome. And that the ones who have much lower IL-18 levels, but maybe have a bit more of an IL-6 predominant, tend to be the ones who start with fevers and those kinds of things, but end up having more arthritis and more articular problems. Okay, so switching to, even if we're not 100% sure exactly what systemic GIA is, we certainly do have tools to try and make it better. And so the goals of treatment are, like they are for every disease, to sort of take care of things as quickly and safely as you can. We want to be careful not to over-treat the patients who we think are going to be just monophasic and expose them to all kinds of drugs with side effects they may not need. But we also want to capture everybody's inflammation as quickly and safely as possible. And so CARA, in its infinite wisdom, CARA is the Childhood Arthritis and Rheumatology Research Alliance, a few years ago put together these consensus treatment plans. And these are basically different pathways that utilize different medicines that rheumatologists can use, and that hopefully down the road we can compare to each other to say which ones are better in which situations. All right, so going through some of the medicines that we use. So NSAIDs, or non-steroidal anti-inflammatory drugs, we often will use these in systemic GIA. I tend to think of them as a Band-Aid. They don't make the disease go away hardly ever, but they can make some of the symptoms, especially the fever and the arthritis, feel better. So one of the mainstays of treatment since the 1800s, well, maybe not that long, but since the mid-1900s has been corticosteroids like prednisone, like methylprednisolone, like dexamethasone. And so steroids are kind of like big clubs that we use to just beat the immune system. They're not very specific. They kind of work on the whole immune system, but they work pretty well because you can use different size clubs. You can use a little bit of steroids. You can use a moderate dose of something like prednisone, or you can bring someone to the hospital and you can pulse them with a big club. And so, steroids remain probably our safest and most effective systemic GIA medicines in the short term. In the long term, they're a mess. So in the short term, steroid side effects include things like increased appetite, some behavioral problems like irritability, and of course, they are immunosuppressive. Pretty much every medicine that we use for systemic GIA is immunosuppressive. In the more medium term, they can cause some cosmetic things that are still pretty disturbing, like causing somebody's face to get all puffy. They call it a moon face, or it can cause fat to accumulate on your back. And some people call that a buffalo hump. These are not very nice names. And then in the long term, the steroids have all kinds of side effects. They're bad for growing people. They prevent you from growing height-wise. They're bad for your endocrine system in terms of they can make you develop diabetes, or if you have diabetes, they can make it worse. They're bad for bones. They're bad for muscles. They're even bad for brains. So as much as we love using steroids because they work and they work so quickly and they're safe in the short term, in the long term, they have all kinds of problems. And that's led us to look for other medicines. And so there's all kinds of small molecules that we've used in systemic GIA. And somewhat simplistically, small molecules are just ways of poisoning your immune system a little bit. And hopefully we poison just the right parts. But like any poison, the more you take, the more toxic it's going to be. And so, we have all different kinds of small molecules, anything from methotrexate, which at the doses we use is a pretty small poison. It's not very immunosuppressive and tends not to cause a lot of problems, to things that are a little bit more bigger guns like cyclosporin or tacrolimus that have some side effects, but are still better than steroids for long-term use. And then some of the sort of bigger guns that we might talk about, like cyclophosphamide or etoposide, that are really quite immunosuppressive, but also work well and work fast. And of course, they have side effects as well. Immunosuppression is common to all of them. And again, sort of dose dependent and drug dependent. And then I've used asterisks because not all of them have the same side effects. And it's sort of beyond the scope of this little talk to talk about which ones are bad for livers, kidneys, or bone marrows. Some can make your hair come out, like cyclophosphamide. Some can make you grow hair in places you don't want it, like cyclosporin. And then some of them, like cyclophosphamide, if you take too much for the long term, can actually increase your risk of cancer down the road. A newer sort of small molecule drug that may be a little bit more specific are called JAK inhibitors. And so JAK inhibitors stand for Janus kinase. And all I really know to know about that is that JAK inhibitors block the signaling of lots of different kinds of cytokines, including IL-6, IL-12, interferon gamma, a bunch of others. And the ones that are available right now are tofacitinib or ruxolitinib or baricitinib. Now, of course, they have side effects as well. They can be immunosuppressive, especially in high doses, and can rarely cause some organ issues or clotting. But for the most part, we're becoming more and more comfortable using these, and they seem to be pretty darn safe, and in some patients, pretty effective. But of course, we're all familiar with biologics and biological molecules. My bias is that I don't think that a biologic drug is any more or less dangerous or safe than any other drug. It all depends on the specifics of the drug and on how you use it. But these drugs happen to be made in a slightly different way. So they're classified differently because they are biologic medicines as opposed to sort of small molecules. The one you might be familiar with is anakinra. Anakinra blocks this IL-1 cytokine. And the way that it blocks it is that it gums up the receptor so that anakinra gets into that receptor and IL-1 can't get in there. But we have other IL-1 blockers like canakinumab or rilonacept, and they are things that sort of bind to IL-1 and kind of suck it out of circulation. Tocilizumab is also a drug that is FDA approved for systemic JIA. It is a floating around soluble version of the receptor for IL-6. So it binds IL-6 pretty tightly and pulls it out of circulation. One of the challenges with tocilizumab is that once you give it to somebody, it can make their C-reactive protein not very reliable because tocilizumab will make the CRP better, but may not always make all the inflammation better. So you have to be careful. And then we have some newer drugs like imipelimab, which was just FDA approved for HLH, but there are trials ongoing in MAS. And it is an antibody that binds to interferon gamma, which we think comes from T cells and is important for disease. And then there are some investigational drugs that block this red cytokine IL-18. There's one called tadakinib, which is not FDA approved, but that prevents IL-18 from binding the receptor. It kind of binds it up. Tadakinib is actually IL-18 binding protein. And then there's an even newer drug that's under investigation in some rare genetic diseases that binds IL-1 and IL-18 at the same time. So, we have a lot of new things that we're gaining familiarity with, and the pipeline is looking pretty bright. In the short term, of course, all these can be immunosuppressive. Because they're so targeted and specific, they tend not to be as immunosuppressive as steroids or some of the chemicals that we talk about. And in the medium term, we do worry a little bit about things like inactivation because these are, foreign proteins. Your immune system can make antibodies to these antibodies and kind of neutralize them. And then the drug doesn't become unsafe. It just doesn't work. And then, of course, like any drug, you can have drug reactions and allergic responses. Okay, so I want to give people a chance to ask questions. So to summarize, systemic JIA is really widely variable. All the patients have fevers, but not everybody else has rashes. Some have arthritis, some don't. But it can be potentially really sort of disabling. And in fact, unfortunately, in severe MAS can be deadly. What causes it is still not clear, but there's certainly this autoinflammatory nature that we don't necessarily see in other forms of JIA. The research is very focused on these cytokines that we talked about. And of course, it's an area of intense investigation. Even, compared to other forms of systemic JIA, even though it's only 10%, there's a lot of people, including myself, who are interested in it. And so I'll plug Mike Umbrello, who's going to talk about some of the up-to-date research on systemic JIA, I think a little later on today. And so I think the future looks bright for systemic JIA. We have lots of new drugs, and we have more coming. We have lots of new research, and we do have lots of targeted, potent, and safe treatments. But of course, we have a long way to go. And so I'll finish with a plug for a new program we have at Children's Hospital of Philadelphia that I'm a part of, called our Immune Dysregulation Program. Internally, you may have heard of this called DIRT, or the Dysregulated Immunity Response Team. This really is sort of a novel way of taking care of kids with really complex immunologic diseases. It's a multidisciplinary clinic that has all of these different subspecialties. And we really have great buy-in from some of the leadership at CHOP, in that our DIRT faculty include lots of the division chiefs of the divisions at CHOP, and you know, they have a whole lot to contribute. So you know, parents or patients can refer themselves, but we certainly work closely with local physicians to get all the research, or get all the records, and make our recommendations and help people sort of work through things where they are, not necessarily have to come to Philadelphia all the time. And so with that, thanks, and I'm happy to take any questions.
Thank you, Dr. Canna. That was a really great talk, very informative. We do have some questions already posted in the chat. Let me start there, and we'll go through those questions. People can still enter the chat, or we can also, we're a pretty small group, so people can also raise their hand, and I can have a verbal question as well. But let me start with some things we have in the chat here. So what's the biggest difference between SJIA and AOSD minus age of diagnosis?
That's a good question. My bias is there's no, because systemic JIA is not a very well-defined diagnosis. I think Still's disease, or adult Still's disease, and pediatric Still's disease are the same disease. Now, when you look in the literature to say, okay, what are the features that distinguish systemic JIA from Still's disease? They're basically things that you'd predict based on the diagnostic criteria. So patients with adult Still's disease tend to have more sore throat, and they tend to have less arthritis. And that's because sore throat is part of the diagnostic criteria for Still's disease, and the diagnostic criteria for adult Still's disease don't require arthritis. And in systemic JIA, sore throat is not, which makes sense because kids get sore throats all the time, and arthritis is required. But when you look at the underlying biology of these two diseases, as far as we can tell, they're the same. I'll add the caveat that there are a few and an increasing number of single gene genetic causes for a systemic JIA-like disease. And of course, these are going to tend to show up more in children.
Okay, I was hoping to follow up with my question, just because I was diagnosed with AOSD, but I also, when I was younger, was diagnosed with just JIA. So I didn't know if there was like any kind of correlation that would have caused my AOSD diagnosis 20 years after being diagnosed with JIA. And then again, with like the medications, I know it seems to be that there's definitely a overlap, but with the specific diagnosis of SJIA versus AOSD, it seems like, at least insurance and FDA wise, that they don't ever try and make it that if it's safe for one, it's safe for the other. So I don't know, I guess from a medication standpoint also, what the differences would be for adult versus kids.
So there's a couple good questions, and I'm so sorry that you've been dealing with potentially one, but maybe two different forms of rheumatic disease in your life. That sucks and is unfair. I'm not aware of there being like there aren't sort of good triggers for Still's disease in childhood that are regular triggers, including, you know, JIA. It is certainly possible, and I don't want to speculate about, you know, individual situations, because, you know, I'm not here sort of as any individual person's doctor. But it's certainly possible that it's always been the same disease your whole life, and it's just sort of looking different in different times. And then the game that we play in terms of getting drugs approved is a nasty game, and I wish it wasn't this way. But there's a lot of patients who I will call systemic JIA in order to get approval for certain medicines, even if I'm not 100% sure that that's what they have. I know what medicine I want to use for them. And I know the insurance approval will be easier if I say they have systemic JIA and I'm the doctor and I get to decide what you have on any given day. And so, I will call you systemic JIA. Unfortunately, there haven't been as many trials in Still's disease. And so unfortunately, and we're working on this, in my opinion, if it's approved for systemic JIA, it should be approved for Still's disease. And that's not always the case. And the reality is simply that insurers make money or save themselves money when they don't approve medicines. And so the reason that they don't approve a medicine doesn't really matter to them most of the time.
Okay, thank you.
Okay, let me go on to another question. How long can someone be in the monophasic stage before it goes away?
I don't know. I think that's a bit of a semantic question. We've certainly had patients percolate along and it took, 3 to 6 months to get things under control. I don't think that there are good data to answer that question, but I would say most of the patients are going to be under pretty complete control within 3 to 6 months if they're going to have a monophasic course. That doesn't mean that there aren't patients that we might call a sort of more chronic course who don't suffer with their disease for a period of many years, and then it just gets easier and easier and then ultimately goes away. That happens a fair amount as well. But it's certainly going to be more common if your disease gets better and stays better within the first 3 months.
Great, thank you. And what about CXCL9? What information do you get from that lab?
Wow, great question. CXCL9 is a chemokine that is produced by lots of different cells in response to interferon gamma. And so we think interferon gamma is really important. Interferon gamma is largely coming from T cells and maybe some other lymphocytes. But interferon gamma is not a great thing to measure in the blood. It doesn't have a very good dynamic range, just like IL-1. IL-1 is almost worthless measuring in the blood. It doesn't mean it's not important. And so CXCL9 is really good for measuring in the blood because it goes up and down really fast. And so often if I want to know how much interferon gamma activity you have, I'll measure CXCL9. Now, the problem is currently, clinically, if I want to check a CXCL9, there's only a couple labs that run it, and they only run it maybe once a week. And so it might be a week before I get your CXCL9 level back. And by then you may be better, you may be worse. I may have already given you half a dozen things, but that's at least why we use it as an interferon gamma response marker.
Great, thank you. What role does IL-1 and IL-6 play?
So IL-1 and IL-6 are these inflammatory cytokines. And I would say, we know a lot about them based on what people have done in the lab, but in systemic JIA, most of what we know comes from treating patients with drugs that very specifically block IL-1 and IL-6. The clinical trials suggest that overall in systemic JIA, they're both really good for fever and arthritis. In practice, I think we tend to use IL-1 blockers more in the patients who have more of the fever MAS type inflammation. And we tend to use tocilizumab, which is a drug that blocks IL-6, more in the patients who have some fevers, but have kind of annoying arthritis.
Great, thank you. What is the percentage of children who get MAS and what is the death rate?
Oh, that's morbid. We think that it depends how you define MAS. And as I said before, MAS is not like a light switch. It is not like you have MAS if you meet certain criteria and you don't have it if you don't. We have to have sort of threshold cutoffs, and probably about 10 to 15% of systemic JIA patients will have true fulminant MAS. Now, often we will hopefully intervene in a way that will prevent someone from progressing to MAS. And so maybe that number will be decreasing because we get better at recognizing and treating it. But anywhere from 40 to 70% of systemic JIA patients will have MAS-like inflammation. They just won't get sick enough to be called MAS, and that's a good thing. We don't want them to.
Great, thank you. My daughter's IL-18 has reached the 400,000 mark more than once, including while on more than one biologic and the JAK inhibitor put together. Is there any hope of an IL-18 blocker in the near future?
I am sorry to hear that. 400,000 is near the highest we've measured. The highest I think we've measured has been 600 or 700, or I think we had one in the millions. But when you get a normal IL-18 level is less than 500. And so when you get into these hundreds of thousands, it's really, really, really high. And there's almost no other disease that it gets that high. This is sort of the basis of what my lab studies. There are 2 IL-18 blockers at least that are in clinical trials right now. Neither of them are in clinical trials in systemic JIA, despite our best efforts. You know, and we're working on that, and hopefully within the next couple of years, they will be approved for something, and then we can try to use them off label in some select patients. We've been able to get compassionate use for one of the newer ones on a couple of patients. So I would talk to your doctor about that. But this newer drug that is FDA approved called emapalumab blocks interferon gamma. And before it was called IL-18, IL-18 was named interferon gamma inducing factor. And so for a lot of patients, certainly not all, but I think a lot of patients with such stratospheric IL-18s are going to receive some benefit from emapalumab. Now, unfortunately, emapalumab is not a good drug for chronic use. So it's great for kind of helping someone get off the edge of their MAS or really severe systemic JIA. It's extremely expensive because it just came out, but it's not a great long-term solution. We're still trying to figure out what the right long-term solutions are while we wait for these IL-18 drugs to get out. But, you know, I recognize that that is not going to be super reassuring to someone whose child is suffering right now. And it sounds like you're getting pretty good care from the drugs you're on.
So what is the age range of your study, and do you take young adults?
My study. So I'm involved in a couple studies. The clinical trials I'm involved with don't really have, none of them really have an age limit, but the clinical trials that I'm involved with are all these IL-18 blockers, and you have to have a certain genetic mutation, either NLRC4 or XIAP, to get into the trials, because the trials are very small right now. And that is something that is a deep source of frustration for the investigators, but we don't own these drugs, and so we don't get to decide exactly what the inclusion criteria are. We have what's called a natural history study, which again doesn't really have an age range. Now, a natural history study is just, it follows the natural history of someone's disease. There's no experimental drug, there's no placebo. It's just more trying to understand why one person gets sick to try and help the next person who looks like that. And natural history studies are the reason that we know things like NLRC4 and XIAP and IL-18 levels and all that, because we're able to sort of reach back and investigate all these sort of complex patients over time. And so I've been involved in natural history studies at the NIH since 2005. We have a natural history study at CHOP. I think the one that I started in Pittsburgh is still ongoing. And you know, all the large institutions have such studies, and almost none of them are going to have age cutoffs.
I think perhaps they were referring to the program you had just mentioned that's going on at CHOP.
So that is not a pure research program. That's a clinical, that's a multidisciplinary clinic for patients with complex immune dysregulation. And I don't know that we have a rigid age cutoff, but it is a children's hospital, and we're not great at taking care of old people. So probably, you know, mid-20s.
Great. Okay. Let's see. Let's move on again. So if the child is currently on, I'm going to pronounce this incorrectly, but canakinumab,
Canakinumab, which I have no connection to. It's a coincidence.
There you go. You can say that. I can't. Which looks like it blocks IL-1. Is that there a way to figure out which of the predominant types they have the IL-6 or IL-18 and a good way to transition to something that specifically addresses these cytokines instead of IL-1? I'm not sure I understand the question.
I'm trying to understand. So
yeah,
the child's currently on canakinumab, which blocks IL-1. That's all it does. In fact, there's an IL-1 alpha and IL-1 beta, and canakinumab only blocks IL-1 beta. Is there a way to figure out which of the predominant types they have? Well, you can measure their IL-18. If their IL-18 is a couple thousand, that's not so high. If it's, 400,000, then you have the IL-18 type. And, canakinumab is a pretty good longer term medicine. And so it's not something we usually transition off of. It's usually actually one of the last things that we take away from folks, unless we think they're having some sort of drug reaction.
Great. So for refractory patients that keep struggling with the disease after trying multiple options available, can BMT be the next option?
It can. I've been involved in, so BMT stands for bone marrow transplant. There's two different kinds of bone marrow transplants that you can do in autoimmunity. One is where you take someone's bone marrow and you give it back to them. That's called an autologous bone marrow transplant. And then there's another bone marrow transplant where you take someone else's bone marrow and you give it to that patient. It's a little bit unclear which type of transplant is the better option in systemic JIA. There's pluses and minuses for both. Autologous transplant is certainly safer because it's your own bone marrow, so you're not going to have rejection problems. Allogeneic transplant has a risk of death of probably about 10% as a baseline under the best of conditions. So these are really sort of drastic measures. There's, a few centers around the country, and the only fair thing to say is that it depends. It depends on the patient, it depends on their situation, and it depends on the expertise of the center. Most centers do autologous transplant pretty much the same way. Centers vary dramatically in how they do allogeneic bone marrow transplants. Obviously we do a lot of those at CHOP. It's been a while since we've done either kind of transplant at CHOP for systemic JIA. Maybe, and I can't say that's because we're so good at preventing people from getting so sick. I think it's just, the way things have shaken out. But yes, this is an option, and there is a literature for it, and there is precedent for it, but it is, a dramatic option. But, in this immune dysregulation service, transplant for systemic JIA is something that comes up in our meetings once a month.
Yeah. Excellent, thank you. So we're running a little bit late. I'm going to do one more question because I know Dr. Canna needs to probably leave, and we're going to take a just break and then go on to our next sessions. But there's one question about Gamifant. Dr. Canna, could you comment on Gamifant used in chronic SJIA?
Sure, I'm finally on top. So I'm looking at Leah's question. Gamifant used in chronic systemic JIA patients that don't currently have frequent full-blown MAS and high IL-18. No, no, not yet. I think we're waiting for some more experience. I think it's as I said, I mean, it's stratospherically expensive. It's only given IV. It has to be given, probably a couple times a week. And so doing an IV medication a couple times a week is not something that we tend to do outside of an inpatient setting. But we are using it more and more in MAS, and there are clinical trials ongoing of Gamifant in MAS. But, whether this is going to be a good sort of chronic long-term drug, I don't know. I'd be a little worried because interferon gamma is really important for fighting a very specific kind of infection called mycobacterial infection. So mycobacteria is tuberculosis, but there are also dozens of other kinds of mycobacteria that we're exposed to all the time. There hasn't been a case yet of someone on emapalumab getting a mycobacterial infection, so this could all be theoretical. But it's not being commonly used that much for a variety of reasons. And then the last question, I'll just jump to, your daughter CXCL9 went from 2,300 to 1,200 in 1 day difference before and after emapalumab. She's using it as an outpatient for the past 7 months. Her IL-18 has gone down, but not the normal range yet. That's great. I think that's good. We'll call that a win. The CXCL9 level is supposed to come down when you give emapalumab. Why the IL-18 level takes so long to come down, we don't know. We are working with a couple centers to try and figure out whether a normal IL-18 level is, we certainly think that if it's normal, then you're in a good place to, if you're otherwise doing great, come off of all of your medicines. But we don't necessarily know that if it's slightly abnormal, that that's not the case, but that's something that we're sort of looking at. So I guess congrats to you for figuring out how to get emapalumab as an outpatient.
Great. Thank you, Dr. Canna. I just wanted to, on behalf of all of the attendees of this session of our arthritis conference in general, thank you so much for being here. It's so helpful for us parents to be informed so that we can have conversations that we need to with our children's providers. So thank you so much.
My pleasure. Thanks for tuning in. And if I can put in a plug, please give Mike Umbrello a hard time in a couple hours. He and I are friends, and you were all very nice to me. I'd like to watch him sweat a little.
I promise we will.
Happy to pass that on. We're happy to do that. I also wanted to thank the planning committee that's here working on these important sessions. It's great to have you. I wanted to thank the Arthritis Foundation, because without them, we don't even have the opportunity to do all of this, and for all of you joining our session. So please take a moment to stretch and move around, and then I think join us in another breakout session in a few minutes. Thank you all. Thank you, Dr. Canna. We so appreciate it.
No problem. Take care.